Hi everybody, and welcome to our first video on renal physiology. Let's start by talking about fluid compartments. The body is made up of 60% water and 40% non-water, and most of that 60% water is found inside of cells. 2/3 of the body water is intracellular, and only 1/3 is outside of cells or extracellular. And of that fluid that is extracellular, 1/4 of it is found in the plasma, so in our vascular system, and 3/4 of it is found in the tissue beds. This is called interstitial fluid. The reason we know how much fluid is found in the different compartments in the body is because of experiments that determine fluid volume. So to understand these experiments, consider that if we took 1 gram of a substance and added it to 1 liter of fluid, we would then get a mixture that had a concentration of 1 gram per liter of that substance. In an experiment, what we can do is add 1 gram of a substance to an unknown volume of the body and then measure its concentration. If we determine that the concentration is 1 gram per liter, then we can back calculate that the volume into which we added that gram must have been 1 liter. And this is the way these experiments are done to determine the volume of fluid in a particular compartment of the body. The two classic substances used experimentally to determine the volume of fluid compartments are inulin and radiolabeled albumin. Inulin is a substance I talk about a lot in the second renal physiology video because it can be used to estimate the glomerular filtration rate. But one of its properties is that it remains in the extracellular space, so you can infuse inulin into a patient, measure the concentration, and determine the volume of the extracellular fluid space. Radiolabeled albumin is just a version of albumin that can be measured experimentally, and albumin has the property that it stays in the plasma. It does not cross capillary membranes, so if you infuse radiolabeled albumin and you measure the concentration, you can determine the plasma volume. So the way these experiments are done is shown at the bottom of the screen. For example, if you infuse X grams of inulin into a research volunteer and the equilibrium concentration is Y grams per liter, then in the case of inulin, which stays in the extracellular space, the extracellular fluid volume will be X divided by Y liters. And this is easier to understand if we use some actual numbers. So suppose we infuse 10 grams of inulin into a research volunteer and the equilibrium concentration in the plasma is 0.25 grams per liter. Then for that research volunteer, the extracellular fluid volume must be equal to 10 divided by 0.25 or 40 liters. So in this manner, we've determined the volume of the extracellular fluid compartment. The same thing can be done with radiolabeled albumin, and this will give us the volume in the plasma. Sometimes on your board exams, the questions will be a little bit more complicated with more math. So let's go through an example of one of those now. Suppose a patient is administered 120 milligrams of inulin, and an hour later, the patient has excreted 20 milligrams of inulin in the urine. At that point in time, the plasma inulin concentration is 1 milligram per 100 milliliters, and they ask you, what is the extracellular fluid volume for the patient? Now, this looks like a lot of numbers, but actually it's very straightforward to answer this question. The amount of inulin in the body for the patient is the 120 milligrams that was infused minus the 20 that left in the urine for a total of 100. The steady state concentration they tell you is 100 milligrams per 100 milliliters. That means that the extracellular fluid volume, which is what they're looking for in the question, is 100 divided by 0.01 milligrams per milliliter, or 10,000 milliliters, or 10 liters. It's a lot of numbers, but very simple math gives you the answer to these types of questions. Now let's talk about how fluid volume shifts between the different spaces in the body. You should be aware that plasma osmolarity is about 300 milliosms per kilogram, and there is an equilibrium established between the fluid inside of cells and the extracellular fluid. And fluid volume is only going to shift from outside of cells to inside of cells if a difference exists in osmolarity. So for example, let's imagine that we have a cell, and inside the cell the osmolarity is 300 milliosms. We can add all the volume we want of fluid at 300 milliosms to the extracellular space. None of that volume will move inside of the cell. It's only going to move inside of the cell if there's a difference in osmolarity between what's inside and what's outside. Now let's imagine we have a cell with 300 milliosms inside of it, and we start adding fluid around it that has an osmolarity of 200 milliosms. In this situation, the fluid is more concentrated inside the cell, so volume is going to be drawn inside of the cell and the cell is going to swell. The opposite would happen if we added volume around the cell that had a higher osmolarity than what's inside the cell. So you have to understand this basic principle that you can add or take away volume all you want from the extracellular space, but it is only going to move into the intracellular space if there's a difference in osmolarity between what's inside the cell and what's outside the cell. There are many clinical situations in which we see the addition or loss of isotonic fluid. This means fluid that has the same osmolarity as plasma, In this situation, the extracellular fluid volume is going to change, but there will be no change in the intracellular fluid volume, and that's because the fluid that is being added or lost to the body is isotonic with plasma. So for example, in the setting of hemorrhage, patients are losing plasma, so they are going to lose lots of extracellular fluid volume, but the volume inside of the cells is not going to change. Another classic clinical example is the infusion of normal saline. Normal saline is a commonly used resuscitation fluid for patients who are hypotensive, and the reason we like to use it is because it has almost the same osmolarity as plasma. This means it will raise the volume in the extracellular fluid compartment, including in the vascular system, but none of it will move to the intracellular space, so there will be no significant change in the ICF. Next, let's consider what would happen if you infused a solution of 5% dextrose into a patient's veins. 5% dextrose is an isotonic fluid that is isotonic with plasma. So initially, when you infuse the fluid, you will be infusing something that is isotonic with plasma. However, dextrose is like glucose, so it will be slowly metabolized by cells in our body, and eventually all the dextrose will get consumed and free water will remain behind. What this means is, as time passes after infusing 5% dextrose, the effect that you will see is the effect of infusing free water into the patient. So you will see an increase in the extracellular fluid volume. You will also see an increase in the intracellular fluid volume, and that's because that free water can shift into cells, raising the ICF volume. Another classic example of fluid compartment shifts is a mannitol infusion. Mannitol is a drug, it's a large sugar molecule, and when it's infused intravenously, it raises the osmolarity of plasma and the extracellular fluid. Importantly, though, it does not cross cell membranes, so it will remain in the extracellular space. So because it raises osmolarity, it will draw fluid out of cells and decrease the intracellular fluid volume, and it will increase the extracellular fluid volume. And so mannitol is useful in some special clinical situations. For example, in cerebral edema, the swelling of neurons can cause damage. So by administering mannitol, you draw fluid out of cells and decrease the intracellular fluid volume. Now let's talk about an important renal and cardiovascular physiology concept, and that's called the effective circulating volume. This is a volume of fluid in the body that you never actually measure. It's just a theoretical concept, and it's the portion of extracellular fluid that's contained in the arterial system and maintains tissue perfusion. In certain disease states, the body can have lots and lots of fluid, but actually very little of it is perfusing tissues. Those patients have lots of water in the body, but they actually have a low effective circulating volume. So this concept is used to explain situations where even though the total body fluid may be up, the effective circulating volume of fluid is down. So as I state here in the slide, this volume is not necessarily correlated with total body water. The major factors that affect the effective circulating volume are the volume of fluid in the vascular system, the cardiac output, and the vascular resistance. In the videos on hypertension, I talk about how your blood pressure is influenced by two major factors, your cardiac output and your total peripheral resistance. The same is true of the effective circulating volume. The cardiac output can go down when there's not much volume in the body, and this cardiac output can also go down if there's a problem with the heart and there's low cardiac output. Both of these lower the blood pressure. They also lower the effective circulating volume. And then anytime the vascular resistance is reduced, that will lower the blood pressure. That also can lower the effective circulating volume. The reason this concept is so important to understanding disease states is because a low effective circulating volume leads to low blood pressure, and it activates two important physiologic systems, the sympathetic nervous system and the renin-angiotensin-aldosterone system. So any time the effective circulating volume is low, these two systems will become active, and that's critical to understanding certain disease states. To understand this, let's look at the chart I've drawn on the screen here. So let's imagine we have a patient with volume depletion. For example, maybe this patient has hemorrhage, or maybe they have nausea, vomiting, and diarrhea, and they're massively volume depleted. That patient will obviously have relatively little total body water. There's not much water or fluid in their whole body. And that patient will also have a low effective circulating volume. So this will obviously activate these two systems, which are a major part of how we respond to volume depletion. Now consider a patient who has heart failure. This patient has a low cardiac output. Patients in heart failure are congested. As I talk about in the cardiology section, they have swollen neck veins and swollen legs. Their total body water is very, very high. But even though it's high, their effective circulating volume is low. It's not low because there isn't enough water in the body. It's low because they have a problem with their heart and low cardiac output. So just like in volume depletion, patients with heart failure have activation of these two systems, and you need to understand that to understand the pathophysiology of heart failure. Finally, let's consider cirrhosis. Patients with cirrhosis are massively vasodilated. They have a very low peripheral resistance or systemic vascular resistance. Both terms mean the same thing. These patients have lots of total body water. They have ascites. They're swollen and full of fluid, but their effective circulating volume is very low, and that's because of the low SVR. So they also have activation of these two systems as part of the pathophysiology of the disease. So the key point here is that you need to understand this concept of effective circulating volume, which is not necessarily the same as total body fluid volume. Anytime this effective circulating volume drops, that will activate the sympathetic system and the RAS system, and that's key to understanding the pathophysiology of all three of these disease states shown on the screen here. Now let's talk about how we evaluate kidney function. So imagine we have a number of patients and we want to know how well their kidneys are functioning. How are we going to do that? Well, the key measurement that we typically use to estimate someone's kidney function is called the glomerular filtration rate. This is a measurement of how much liquid passes through the filter, i.e. the glomerulus, per unit time. And you can determine this from plasma and urine measurements. And I'll talk about how to exactly determine the glomerular filtration rate, in other words, to get a number for this rate in the second renal physiology video. But the reason we like to evaluate kidney function with the GFR is because it falls as the kidneys fail. As the kidneys start to get sicker and sicker, they filter less fluid and the GFR falls. There are some other metrics of kidney function that we also use. One is the amount of blood or plasma flow. This is how much blood is entering the kidneys. And the other one is called the filtration fraction. So this is the ratio of the GFR to the renal plasma flow. So for example, if the renal plasma flow is 10 liters per minute, but only 5 liters per minute are being filtered across the glomerulus, that would give us a filtration fraction of 50%. And this is another measurement we sometimes use to talk about how healthy the kidneys are and how well they're functioning in health and in disease states. As a student, I recommend that you think about the measurement or the determination of the glomerular filtration rate in two ways. One way is the theoretical determination of GFR. This is what I'll focus on in this video. This has to do with the pressures and the forces in the capillaries and in Bowman's capsule that determine the GFR. The second way to think about GFR is the clinical determination. This is the way to actually calculate a number for the GFR. To do this, you need plasma concentration of solutes and urine flow, and I'll talk about all the math in measuring the actual number for GFR in the second renal physiology video. In order to understand the theoretical determinants of the GFR, you need to understand the driving forces for glomerular filtration. And there are basically two forces that drive solutes and fluid across the glomerular membrane and into the nephron. Those two forces are the hydrostatic pressure in the capillaries and the oncotic pressure in the capillaries. So we're going to talk about both of these and how they affect and determine the GFR. Shown on the screen is my own drawing of a glomerular capillary. So let's imagine that we have fluid flowing into this capillary carrying solutes. Some of the fluid and solutes will cross the glomerular membrane and enter into Bowman's capsule or Bowman's space. Others of the fluid and solutes will exit the glomerular capillary in this direction. So what we want to talk about are the forces that are going to determine the amount of fluid that crosses into Bowman's space. The first force is called the hydrostatic pressure. This is what you think about when you think about your blood pressure. It's the fluid force pushing against the walls of the glomerular capillary. And a high pressure tends to drive fluid toward a low pressure. So for example, if the hydrostatic pressure in the glomerular capillary were 10, and we had a hydrostatic pressure in Bowman's capsule of 5, then we would have a net driving force of 5 in this direction to drive fluid flow across the glomerular membrane and to create glomerular filtration. The other force that's important in the capillary is the oncotic pressure. This is a pressure created by solutes, especially albumin, and a concentrated solute tends to pull fluid into the glomerular capillary. And what's confusing about oncotic pressure is that a high pressure value tends to draw fluid away from a low pressure. So for example, if we had an oncotic pressure in the glomerular capillary of 10 and we had an oncotic pressure in Bowman's capsule of 5, that would tend to drive fluid in this direction. But nevertheless, it's just another force controlling fluid movement. And the summation of the hydrostatic pressure force and the oncotic pressure force is going to determine the amount of GFR. In other words, the amount of fluid and solutes crosses this membrane and enters into the nephron. Here's a slide from the video in the cardiology section on regulation of blood pressure. In that slide, I talk about fluid exchange in the systemic capillaries. And I won't go through this slide now, but I just want to point out to you that the same two forces, hydrostatic pressure and oncotic pressure, control fluid movement into and out of systemic capillaries just like they control fluid movement in the glomerular capillaries. So getting back to the glomerular capillaries, what factors are going to change or alter the glomerular filtration rate? Well, if you want to change the glomerular filtration rate, you can change either the hydrostatic pressure in the glomerular capillary or the hydrostatic pressure in Bowman's capsule, or you could change the oncotic pressure in the glomerular capillary or the oncotic pressure in Bowman's capsule. Any changes in these forces are going to affect the glomerular filtration rate, and that's the way we think about the GFR in theory. We don't usually actually measure the GFR from these forces, but we think about certain disease states that alter these forces and how that affects the GFR. Before we go any further in our discussion of GFR and capillary hemodynamics in the kidneys, we have to pause and talk about two very important structures in the kidneys, and those structures are the efferent and afferent arterioles. Normally, you have an arteriole that feeds blood into a capillary, for example, in the periphery, and then that capillary drains into a venules. The glomerular capillaries are different. They do not drain into venules. They have an arteriole on both sides. The arteriole that feeds the capillary is called the afferent arteriole, and the arteriole that drains the capillary is called the efferent arteriole. You can just remember the E for exits and the A for arrives in terms of the glomerular capillary. The reason our kidneys evolved this way is because this allows us to vasoconstrict either the blood flow coming into the capillaries through the afferent arteriole or the blood flow exiting the capillaries through the efferent arteriole. And by vasoconstriction, on one side or the other, we can manipulate the hydrostatic pressure in the glomerular capillary, and that's very important for the way our body controls and alters the GFR. So now that we understand that, let's talk about what would happen to the glomerular filtration rate if we altered either the hydrostatic pressure or the oncotic pressure in the glomerular capillaries. And let's start by talking about what happens when you raise the hydrostatic pressure Pg sub C in the glomerular capillaries. One of the ways this can be done is by dilating the afferent arteriole. That allows more blood to rush into the glomerular capillary, and that will increase the renal plasma flow of blood flowing through this capillary. That will also raise the hydrostatic pressure Pg sub C. Why would this happen? Well, we're stuffing more molecules into this capillary, therefore we are going to raise the hydrostatic pressure Pg sub C. And remember, this pressure is a driving force for the glomerular filtration rate, so when we do this, the GFR will increase. And because this change, dilation of the afferent arteriole, increases the GFR and it also increases the renal plasma flow, then the filtration rate, which is the ratio of these two, is not going to change. In other words, if the GFR goes from, let's say, 10 to 20, but the renal plasma flow goes from, say, 100 to 200, we maintain the same ratio of a filtration fraction and there's no change. Another way that we can raise the hydrostatic pressure in the capillary is by constricting the efferent arteriole. So if we constrict the outflow of blood from the capillary, this is going to raise the hydrostatic pressure in the capillary because blood molecules are going to back up behind this obstruction, and that's going to raise the pressure here. That is also going to increase the GFR, just like we talked about with dilation of the afferent arteriole. However, in contrast to dilation of the afferent arteriole, less blood is flowing out of the capillary, and there's an overall decrease in the amount of blood that is flowing through this system. So in this situation, we get an increase in the GFR, just like we saw for dilation of the afferent arteriole. However, we get a decrease in the renal plasma flow, and for that reason, we see an increase in the filtration fraction. In other words, more of the blood that goes into the capillary is being filtered and less of it is exiting the capillary. What if we change the oncotic pressure pi G sub C in the capillary? We can do this if we increase protein levels in the blood. Remember, proteins, especially albumin, are very important for generating that oncotic pressure pi G sub C. If we raise this pressure, that will draw more fluid into the capillary and resist the movement of fluid out of the capillary. That is going to reduce the GFR. In general, changes in protein level do not affect the renal plasma flow. In other words, blood continues to flow through normally. It's just that less of it moves across the membrane and into Bowman's capsule when there are more proteins in the plasma. So for this reason, we see a decrease in the filtration fraction because we are decreasing the GFR, but the renal plasma flow is not changing. Therefore, the filtration fraction goes down. And there are many disease states where the protein levels rise in the blood, for example, multiple myeloma. And in those states, there can be a lowering of GFR for the reasons shown on this slide. Now let's talk about what would happen if we change the hydrostatic pressure in Bowman's capsule. Remember, this hydrostatic pressure resists the flow of fluid out of the capillary and into Bowman's space. One way that this pressure in Bowman's capsule can get very high is if there's an obstruction of the ureter, for example, from a kidney stone. This will back up urine behind the obstruction, and the pressure in Bowman's capsule and all the nephrons will get very, very high. When this happens, there will be less glomerular filtration because of this high pressure in Bowman's capsule. There's no effect on renal plasma flow. Blood will continue to flow through the system normally. So what you will see is a fall in the filtration fraction because we've got a drop in the GFR, but we have no change in the denominator of the filtration fraction equation, which is the renal blood flow. So on this page, I've summarized the glomerular flow dynamics we've been talking about in the last few slides. There are many disease states and drugs and other situations where all these things shown here can be altered, so it's important to understand the effects that these have on renal plasma flow, glomerular filtration rate, and the filtration fraction. So if we start with afferent arterial dilation, that will increase the renal plasma flow and the GFR, but have no effect on filtration fraction. If you were to constrict the afferent arterial, the opposite effects would occur. If you constrict the efferent arterial, that lowers the renal plasma flow, raises the GFR, and increases the filtration fraction. And if you dilated the efferent arterial, that would have the opposite effects. Raising the amount of proteins in the plasma and the osmolarity of the plasma has no effect on plasma flow, but it does decrease the GFR and the filtration fraction. And then finally, obstruction of a ureter blocks the flow of urine out of the nephron, including out of Bowman's space. That has no effect on renal plasma flow, but it reduces the GFR and it reduces the filtration fraction. I'll finish this video by talking about autoregulation of the kidneys. So over the course of the day, if you could see your blood pressure, you would see that it sometimes goes up and it sometimes goes down. Even though it's always within normal limits, if you're not hypertensive, it still can go up and down within normal limits depending on what you do. For example, when you sit or stand, your blood pressure can change. When you drink water, or if you don't drink water, your blood pressure can change. And if your kidneys weren't able to regulate the blood flow, then the amount of blood being filtered would vary widely during the day, and this would make the kidneys very inefficient. But luckily, the kidneys can do what's known as autoregulation. They can maintain a constant GFR and renal blood flow over a range of blood pressures. This is what GFR and renal blood flow look like shown on the screen here. The mean arterial blood pressure is on the x-axis, and the flow rate for the renal blood flow, or GFR, is on the y-axis. And you can see that anywhere from about 80 up to about 200, the kidneys can maintain the same blood flow and the same GFR. This process is called autoregulation. Only if your blood pressure gets very, very low do you start to see a drop in renal blood flow and GFR. And there are two major mechanisms by which the kidneys autoregulate their blood flow and the GFR. Those are called the myogenic mechanism and tubuloglomerular feedback. The myogenic mechanism refers to the ability of the afferent arteriole to constrict in response to high blood pressure. This arteriole responds to changes in stretch, and when the pressure goes up, the arteriole gets stretched and it responds with vasoconstriction. So if we look at this drawing on the screen here, imagine that the afferent arteriole senses high blood pressure coming from the renal arteries in the vascular system. It will respond by vasoconstricting. This will allow less blood to enter the capillary, and it will maintain a normal hydrostatic pressure in the glomerular capillary despite the higher blood pressure in the systemic vessels. And the result is maintenance of normal glomerular filtration rate and renal plasma flow over a wide range of pressures. Tubuloglomerular feedback refers to the fact that anytime the GFR goes up, there's more urinary flow in the tubule. And since there's always sodium chloride in tubular fluid, this means more sodium chloride will be delivered to the distal tubule. In the distal tubule, there is a structure called the macula densa, which is part of the JG apparatus, and it senses the increased sodium delivery, and it responds by telling the afferent arteriole to vasoconstrict. So let's look at our drawing again and imagine that the blood pressure were to go up out here in the systemic vessels and that more blood flow were driven into the capillary. That would cause the GFR to go up. This would be sensed by the macula densa, which would then trigger the afferent arteriole to vasoconstrict, and we'd get the same phenomena we talked about for the myogenic mechanism. The hydrostatic pressure in the capillary would fall and the GFR would come back to normal. And this is the second major component of autoregulation in the kidneys. Here's an image of a glomerulus, and I just want to show you how close together all these structures are. So this is Bowman's capsule here, this white part right here. We've got the distal tubule out here, and right between the glomerulus and the distal tubule is the JG apparatus. That's where you can find macula densa cells, which are modified distal tubular cells. That's also where you can find the cells of the afferent arteriole that vasoconstrict. So this whole JG apparatus is sensing blood pressure and responding with afferent arteriole vasoconstriction to maintain normal renal blood flow and normal GFR over a wide range of blood pressures. I'll finish with this slide and discuss severe volume loss. So severe volume loss occurs when patients have a profound loss of fluid, for example, vomiting and diarrhea or massive hemorrhage. In this situation, the blood pressure gets very low and the renal plasma flow falls significantly. And you need to be aware that when there's significant volume loss, the autoregulatory mechanisms are overwhelmed. All those autoregulatory mechanisms basically are designed to work within a range of normal blood pressures like you experience throughout a normal day. They're not going to work if you have a massive hemorrhage and are in a state of hemorrhagic shock. So if you look at this drawing on the screen, when the mean arterial pressure gets very low down in this range, the GFR starts to fall and the renal blood flow falls. The autoregulatory mechanisms cannot keep up at these low pressures. So in this situation, the GFR will fall, BUN and creatinine will rise, and pre-renal failure will develop. So this is often a confusing concept for students. They're familiar with renal autoregulatory mechanisms and they're faced with a question of a patient in shock. You should be aware that those mechanisms aren't going to work in the setting of severe volume loss. And that concludes our first renal physiology video.